Hello, everyone, and welcome to the second episode of the Insights by EHA monthly webinar series, where we discuss key relevant global health issues with global health experts from around the world. And thank you for joining the conversation. My name is Nana Ohiri, and I'm a project manager with eHealth Africa, and I will be moderating this session titled Integrated National Serosurveillance, Unlocking Data for Public Health Action. For background, EHA, we're currently implementing an integrated national serosurveillance project with the CDC Foundation, the CDC in Nigeria, and the National Reference Lab here in Abuja to improve the capacity of the facility to conduct integrated serosurveillance. We'll be diving into that more with the help of our panelists today. So I'll now hand over to our Deputy Director, Programs and Impact, David Akpan, for the introductory remarks. Over to you, David.
Hello, good afternoon, everyone. I hope you can hear me. So my name is David Akpan. Okay, so to welcome everyone to this webinar series, EHA Public Health Insight webinar, and to thank you for finding time to join our second series of this webinar, and also to appreciate our guests who will be providing us further insight around the topic for today. So we'll be discussing very deep details, things around how unlocking data for public health action can improve national surveillance, serosurveillance. And we appreciate that our participants today will definitely utilize the learnings from this to improve some of the discussions and some of the work that we're doing. So welcome, and let's have a good and a very fruitful conversation. Thank you.
Thank you, David, for that introduction. So we have two esteemed guests on our panel today. From the CDC Foundation and the Institute of Human Virology Nigeria, and they will be sharing their insight and expertise and building our knowledge on the subject matter. So we will begin with introductions from our panelists, which will be followed by a joint presentation by our panelists and a brief discussion and the Q&A with you, the audience, where you can ask your questions either by raising your hand or putting it in the chat box. Also, there will be a post-webinar survey at the end of the webinar, so please stay through to the end of the webinar to be able to answer that survey for us. Thank you so much. So I will now hand over to our panelists to introduce themselves. Let's start with you, Emeranda.
Hi, good morning, good afternoon, everyone. My name is Miranda Bodfish, and I'm currently serving as the Associate Vice President for Infectious Disease Programs at the CDC Foundation. We're based in Atlanta, but work with CDC programs around the world. I've been at the Foundation for about 2.5 years, but before that was working at CDC Center for Global Health in various global program management roles. I'll talk a little bit later about our role in this project, but I'm really excited about the opportunity to speak about integrated serosurveillance today. Thank you.
Thanks so much, Miranda, for your introduction. Over to you, Dr. Ado.
Yeah, good morning, good afternoon, everyone. I'm Ado Abubakar. I'm the project director for the Multiplex Bead Assay. I work for the Institute of Human Virology Nigeria, but my lab is based at the National Reference Lab under the Nigerian Centers for Disease Control. I have been working on surveillance and laboratory for like 20 years now, but with IHBN about 11, 12 years. And on this project, we have been like 2.5 years now. Thank you.
Thank you so much, sir. So on the agenda for today, we'll move on to the presentation by both our panelists, and then of course the Q&A and then questions from the audience. We'll have our closing statements and then post-webinar survey for the audience. So IT, please can you project the presentation? IT team, can we get the presentation on the screen, please? Thank you. Thank you so much. So, Dr. Ado, I believe you begin the presentation.
Yeah. So the topic we are discussing today is Integrated National Serosurveillance Project in Nigeria. Next slide, please. Next slide. Yeah, so we are going to talk about the project's vision, mission, and background. I will have been the one controlling this, but no problem. Okay, so low middle income countries do not have sufficient data about disease surveillance to enable them monitor the impact of public health efforts within the countries. So serosurveillance help in providing estimates of antibodies and also antigens against diseases, considering that we have a very sensitive way to monitor immunizations, to monitor exposures to diseases, to also conduct disease outbreak investigation, and also monitor emerging pathogens like SARS-CoV-2, for instance. So the serosurveillance that is normally done is just for a single disease. But the multiplex or multiple disease surveillance, which is the integrated surveillance, like in Nigeria, we also have IDSR. One is more cost effective because it gives a better data that will help in informing public health decision for action. It increases the quality of data, both nationally and globally. It also is very useful in disease modeling and efforts to describe transmission risk. It also provides information on implementation, monitoring, and prevention of diseases across multiple diseases. It also provides surveillance information for diseases that are currently unmonitored, like emerging diseases. Next slide, please. Can I have the next slide, please? So what happened in our own case, we are using the multiplex Bead assay, using MarkPix technology here to conduct an integrated serosurveillance. CDC HQ developed an approach that can be able to measure several number of antibodies, up to 100, including antigens, using one single DBS, dry blood spot. And you just need like 5 microliter from the eluent. This has given us a novel opportunity to establish an integrated national serosurveillance program in Nigeria. Some of the diseases that we have the capacity to test include the NTDs, neglected tropical diseases. You can see lymphatic filariasis, onchocerciasis, trachoma, yaws, all those. Also vaccine preventable diseases, tetanus, diphtheria, measles, rubella. We also look at waterborne and foodborne infections, and you can see a whole list, including Campylobacter. Waterborne diseases, including malaria, Zika. Some of the emerging ones that NCDC is interested in is chikungunya. It has not been very popular, but we hope to work on that in the future. Onchocerciasis work is ongoing already. You can see yellow fever, West Nile, and also Japanese encephalitis. Can we look at the next slide, please? Can I have the next slide? Okay. So this is the wonderful MarkPix instrument developed by Luminex, and it has the capacity to analyze up to 50 analytes in one single specimen at the same time. It is based on fluorescence. It's called New Generation Assay. If you remember the enzyme immunoassay that can be able to pick up to the level of 4th generation EIS that can pick both antigen and antibodies, use the recombinant technology. But this is far advanced because it's more sensitive, more specific, because it uses fluorescence. MFI, the mean fluorescent intensity, that is what we use. Thank you. Can you move to the next? The major objective of the NMS4 project is to better understand disease epidemiology and also provide valuable information for public health action in Nigeria. The primary objective is to give estimate of malaria in Nigeria, that the prevalence. Also look at the seroprevalence of vaccine preventable diseases. To also estimate seroprevalence of other diseases of public health importance or interest in Nigeria. For the neglected tropical diseases, we looked at the antibodies, and this have to do with like lymphatic filariasis, onchocerciasis, schistosomiasis, soil transmitted helminths, strongyloidiasis, teniasis, trachoma, and yaws. Some of these diseases have even been forgotten, and people think that they're all over, but from this study, we can see some areas of interest in Nigeria that need attention. For instance, trachoma in children under 5, we even have a publication on that, and it's really an area of new interest. Food and water diseases such as cholera, E. coli, and all those. We also look at them. So that is what NMS4 is all out to do. And NMS4 was able to help even the National Malaria Elimination Project of Nigeria in securing a grant because we did geospatial mapping for the first time, and that data was very useful. Next. The technology here is not diagnostic. We don't test patients, clinical patients, to say, oh, you are positive or you are negative. The essence of this surveillance is to use the panels to determine disease burden in order to guide the government of Nigeria in public health intervention. We have had NICE, the Nigerian AIDS Indicators Impact Survey, which was a population-based survey, a household survey around July to December 2018 within 36 states and FCT. 1,055,000 households were targeted with about 172,604 participants. On the completion of the project, we were able to go home with 97,250 households, 97,250 households, then with 225,169 participants. So that was a survey that MBA is riding at the back of. Next. Next slide, please. Hi, moderator, next slide. The NMS4 project used remnants of the NICE samples to test for these diseases of interest. Of priority, we look at children 0 to 14 years. We also look at the children 0 to 14 years were 32,000. Then the women of reproductive age, 10,000. We look at them. We look at all these multiple diseases in them. Some of the ongoing projects include the Trend 3, which we are currently doing, but the PMI has been completed already, which was 51,000 specimens in 10 states in Nigeria under the Presidential Malaria Initiative program. Next, please. Currently, we are looking at the remaining adult patients. The target was about 121,000 samples, but because of close out, we are looking at about 36,000 samples. I think it's time for Miranda to take over from me.
Yes, thank you, sir. Thank you, Dr. Ado, for your presentation. Over to you, Miranda. Thank you.
Wonderful. Thank you, Otto. So I'm going to speak about partnerships for integrated serosurveillance. Next slide, please. So first, as a little bit of background, some of you may not be familiar with the CDC Foundation, and our role is to unleash the power of collaboration between CDC and other partners such as philanthropies, corporations, other governments, or individuals. And we're trying to bring those interests together to have greater impact on public health priorities. Next slide. We are an independent nonprofit organization, but we are fully dedicated to supporting CDC's mission. We are authorized by the US Congress to create and mobilize philanthropy and partnerships to support CDC. And some of our areas of focus in collaboration with CDC are fighting outbreaks, reducing healthcare spending, and providing essential guidelines and health data. Next slide. We work with partners and CDC on a number of technical priorities that fall under safeguarding Americans' health, fighting global health threats, responding to emergencies, developing disease fighters. We have some specific funds or causes for specific disease. Sorry, I was muted. Can you hear me okay, Nina? Okay, great. And some of our partners include other foundations and philanthropies, corporations and businesses, other nonprofit organizations, educational institutions, US or international government agencies, and individual donors. Next slide. Our role is to work alongside CDC and partners, where CDC leads the scientific aspects of a project, and we bring 25 years of program management experience to extend the impact of philanthropic contributions. And we work at all stages of the program strategy. So starting at the design and innovation stage, developing pilots and proofs of concept, building capacity and strengthening existing systems, and amplifying public health efforts to reach a wider audience. Next slide. And this has some animation, so you can just skip through that. So for the work on integrated serosurveillance, our focus with CDC is to support CDC in promoting integrated approaches to serosurveillance, expand the use of multiplex-based technologies for integrated serosurveillance, and scale up capacity for integrated serosurveillance in Africa. Next slide.
What approach did you say? Okay.
So we work with CDC subject matter experts, and there are other partners involved in this larger effort that Otto spoke to. There's been support from PEPFAR, the President's Malaria Initiative, Global Immunization Resources, and Global Fund. Today, I'm going to focus on funding that came from the Bill and Melinda Gates Foundation to CDC Foundation. And then on the implementing side, we work with the Nigeria Centers for Disease Control and their National Reference Lab, IHPN, and eHealth Africa. And today I'm going to speak about our work with IHPN and eHealth Africa. Our funding from the Bill and Melinda Gates Foundation was intended to fill some gaps in the existing resources to scale up integrated serosurveillance, focusing on Nigeria. The objectives of this grant are to expand capacity at the National Reference Lab and Nigeria CDC. So looking to support NRL to be able to conduct multiplex testing and quality control, and to be able to have staff participate in the management, analysis, and dissemination of this complex data related to multiplex testing. The second objective is to develop a set of tools that can assist other countries who are embarking on integrated serosurveillance. So the CDC team is working on documenting best practices and compiling resources for multiplex-based integrated serosurveillance that can be shared with other countries and partners. And then finally, and most importantly, the goal of this grant is to provide the results from the testing for multiple diseases to ultimately inform public health programming in Nigeria. Next slide. So the partners that we at the foundation work with directly on implementation are IHPN and eHealth Africa. And some of you may be familiar with these organizations' roles on this project, but just to recap, we've engaged IHPN under Otto's leadership to support the National Reference Lab MBA laboratory to test stored specimens, support technical assistance and capacity building, and support dissemination of results and availability of the data to inform public health programming in Nigeria. And then we worked with eHealth Africa on a number of aspects of this important initiative. Initially, we worked with eHealth Africa to assess the infrastructure at the NRL to collect, store, and analyze samples and data using the multiplex technology. Then we engaged a team to do some very significant upgrades to the ICT, power system, and data system that were needed in order to ensure that the NRL could conduct integrated serosurveillance. Currently, eHealth Africa is providing help desk support to troubleshoot any issues that arise with the ICT and power system. And then the final area of work will be to develop and deploy custom report from the NMS4 data system. Next slide. I'll turn it back over to Otto for progress and future directions.
Thank you, Miranda.
Yeah, thank you, Miranda. My camera was high above the wall because of the teleconference facility within the lab. So maybe once in a while I can be standing up so that my face can be conspicuous. But I hope my voice is conspicuous, most importantly. So the progress and future directions. Next slide, please. So this is the history or the project timeline. Between July and November 2019, there was a training at CDC Atlanta for 3 lab managers and also at NRL for the members of the team. Around November 2019, testing began. That's tranche 1. And we started with the priority samples, that the children 0 to 14 and the 10,000 women of reproductive age. February 2020, there was concept note, which was developed on malaria with the Global Fund. Around March 2020, Nigeria Measles and Rubella Strategy Workshop was conducted. In July 2020, we look at the maternal and neonatal tetanus elimination to see the progress, and that was done among the women of reproductive age, which was 10,000 specimens. In August 2021, tranche 2 started. We are done with tranche 1, and approximately 52,000 samples were tested. From August 2022, or earlier than even August, because we have already gone beyond that. So far, we have done about 30,000 specimens. We are currently on tranche 3. Next slide, please. Next slide. As I mentioned earlier, this project has provided the first data on malaria prevalence in older children and measles, also rubella seroprevalence among the same age group. That has helped the National Malaria Elimination Program also. The neglected tropical diseases and practice diseases data from the first tranche, that's tranche 1 of specimen, has expanded our understanding of yaws and trachoma transmission. And it was very clear, particularly trachoma, you will see around northwestern Nigeria, there are still issues which can cause blindness in children. So that calls for public health intervention by government of Nigeria. The immediate program impacts include improved application of resources and more detailed plans to focus on prevention services for those most needed. The MBA laboratory has allowed Nigeria to develop accurate estimates for SARS-CoV-2 prevalence and to track the COVID-19 epidemic. We were able to evaluate a kit to validate it. That's XMAP, with a very fruitful result. Also the in-house beads from CDC Atlanta. And even currently, some activities on SARS-CoV-2 are ongoing. Next. We have had a lot of publications from this project within this short period of time, like on SARS-CoV-2, on the American Journal of Tropical Diseases, Tropical Medicine and Health. +1, we had another publication, even at the International Conference for the American Society for Tropical Medicine and Hygiene. We have several number of abstracts. We did a lot of data analysis on trachoma, which is really very helpful to Nigeria. Some of the publications are in draft, like the rubella surveillance, looking at the women of reproductive age, triangulation, rubella spatial modeling and estimates, and several other work being done. And some of the things we discovered, like the history-rich protein 2 deletion, which we are hearing in other countries for the first time, that has been found very valuable in Nigeria, where you see that the rapid test kits for malaria will mislead diagnosis and give a false negative result. But due to this technology, we're able to pick. So analysis that are ongoing and some that have been completed include that of trachoma and some enteric diseases. So really it's a project that's small but mighty, because the public health importance of this project cannot be overemphasized. Next. Next slide. Yeah, so way forward, we need to leverage and expand on this great work done in Nigeria and other countries. We need to build NCDC's network with WHO to have a good representation in West Africa and even entire Africa. There is really a great interest in having regional laboratories that will be doing this great surveillance. So there should be a summit to discuss way forward on implementation and expansion of this surveillance through the laboratory networks. This requires continued support for the NCDC, the NRL, and the MBA laboratory, and other international laboratories. Thank you.
Thank you, Dr. Ado. Thank you for that. Thank you, Dr. Ado and Miranda, for that rich presentation. And as you said, it's a novel area of interest for global health. And I'm sure that there are some people in the audience now who this is their first introduction to integrated serosurveillance. So thank you for building our knowledge on that and sharing your expertise on the subject matter. So I have a few questions from that, and I know that you mentioned a few different type of diseases that are currently being used for serosurveillance, like the NTD, the waterborne diseases, and the vaccine preventable diseases. I want to ask, is there any limitation to the type of disease that can be used for integrated serosurveillance? I'll pose that to you, Dr. Ado, and also if you have any insights on that, Miranda.
Yeah, there is no limit to what the multiplex-based assay technology can do, and there are also no limit to which disease, but the catch here should be of public health importance. So it's the decision of the policymakers, health administrators, public health experts in any country to decide. I gave an example with chikungunya. NCDC is interested in that, even though it's just emerging. Yeah, and you know now that we are talking about monkeypox in Nigeria. So it's as it goes, then you now say this is more important. And of course, the policymakers have to take decision. Once the beats are there, they can be coupled. Sky is the limit. Thank you.
Thank you for that answer, Dr. Ado. Miranda, do you have any additions to the questions?
Sure, just to add, and this is not my area of expertise at all, but it's my understanding that the CDC team in Atlanta is regularly working to see what can be added, but there are a number of technical issues to work through in expanding the assay, but that is an area of interest and priority as different priority diseases arise. Thanks.
All right, great, fantastic. So do you think that for integrated national serosurveillance, it's only LMICs that could benefit from such a project, or do HICs also, there's some benefit to integrated serosurveillance in the HICs, or is it just strictly for LMICs, since they are the countries that usually have a lack of data for this kind of projects? Dr. Ado.
I thought the question is for Miranda.
Oh, for either of you, for either of you or for both of you, I would like to hear.
Can you just recap the questions to make it clearer?
Okay, so like you said in your presentation, it's you mentioned that LMICs are the countries that have issues with lack of data for serosurveillance. So I'm asking that, is there any benefit of serosurveillance to HICs, even though they have more access to more data for public health issues?
Okay, Miranda, would you like to start responding?
Sure, I can speak to that a little bit. The research that I'm aware of on integrated serosurveillance has been focused on low and middle income countries. However, at the CDC Foundation, from the perspective of higher income countries, we are very interested in data modernization and looking at ways that information systems for public health can be streamlined and more efficient to provide better data. So I think there could be some lessons learned from integrated serosurveillance at how countries can look at multiple diseases in an integrated way to understand public health priorities for their populations.
Okay, fantastic, thank you.
So maybe I would just add that from our experience, apart from the diseases we just mentioned, this project was able to help the HIV program in Nigeria in trying to validate the national HIV testing algorithm using the same MBA technology. And I'm also aware that the project can be very valuable even in blood transfusion services. At least you can do a surveillance among donors and find out if there are other emerging diseases and all those. So really there are several number of benefits apart from just what we highlighted. Thank you.
Thank you for that. And I have just one last question. So we COVID-19 hit the world in 2019, and it seems like both the health systems of both the LMICs and HICs were greatly affected by the pandemic. And we're currently in year 3 of COVID. And then we also have monkeypox, which has just been declared a public health emergency by WHO. And then we also have the Marburg fever that was just identified in Ghana. So there seems to be like many outbreaks that are just coming up one by one. So I want to ask, do you think there's any benefit of the surveillance to help us predict and prepare for such outbreaks? And Miranda, you can start first, and I'll go to that.
And are you asking then specifically about integrated serosurveillance to predict outbreaks?
Yes, integrated serosurveillance.
Sure. So my understanding is that it's most effective at looking at things like coverage of immunization or cross-checking with NTD surveillance to see if there are hotspots that are being missed. So from that perspective, yes, it could certainly potentially point to areas where there's a potential for outbreak. But I think a lot of work is needed to strengthen systems and to be able to, collect specimens, test them, and analyze the data in a really timely manner in order to have that information before an outbreak hits. But I'd love to hear Otto's thoughts as well.
Okay, great. Dr. Adam, your insights there? Okay,
you can also even make it in retrospect. Look at the history. For instance, this specimen that we are working on are DBS that were collected since 2019. And you can even check to see whether something has been happening or what the relationship between malaria and SARS-CoV-2 and all those. So it's not just what is happening currently, but you can make predictions and simulations from all the information you have. Very valuable because we have a great biorep. Thank you.
Great, thank you so much for your answer, Dr. Addo. And I'm going to now go over to the questions. I see some questions from our audience, fantastic. So Lungi Okoko says, thank you for sharing the Nigerian experience. And she or he asks, to what extent could this multiplex approach be used systematically for all household surveys conducted by the Demographic and Health Surveys? And also, has the CDC Foundation initiated any dialogue with the DHS program team at ICF to explore whatever opportunities to expand the use of this approach to as many countries as possible? So I think we'll start with the first part of the question. To what extent could this multiplex approach be used systematically for all household surveys conducted by the Demographic and Health Surveys? Dr. Addo, I think you're in the best position to answer this question. Dr. Adosa, can you hear us?
Our funders will be in the better position to answer this question since it's about expanding to other countries. But from what I know, already we are helping other countries. Is it Mali? We just trained some people from Mali, and it's a very good collaboration. And we are thinking of some other countries too that we can help. As we said, this lab will be a hub, a regional lab for the entire West Africa and eventually for the whole of Africa. So we can help build capacity and make other countries have capacity to be able to conduct the same survey that we are doing. So that's really the way to go.
Okay, so so in your presentation, the survey that you mentioned was the NAIS survey. So Lungi is asking if we could use this multiplex bead assay approach for other household surveys that are being conducted.
Of course, sure.
Great, so that's the question. Okay, great. Fantastic. So for you, Miranda, has the CDC Foundation initiated any dialogue with the DHS program here in Nigeria at ICF to explore whatever opportunities that there may be to expand the use of the MBA to as many countries as possible?
Sure, those are great questions and very insightful, because I do understand that one of the challenges in expanding integrated serosurveillance to other countries is that it's very costly to conduct serosurveys. And so building on existing surveys is definitely part of CDC's longer term vision. We at CDC Foundation have not yet engaged in discussion with other partners about expanding this, although it's definitely something that we are working with CDC to determine who are the best partners for us to engage with, whether it's to support work in other countries or to support additional work in Nigeria. And so it's definitely an ongoing conversation, and we hope that the successes from Nigeria can be used to inform conversations with other partners in the future. Thanks.
All right, great. Thank you so much for that. Please, audience, please keep sending in your questions for our panelists. We have another question. It says, from your findings, what would you say is the disease burden of MPDs? That will be for you, Dr. Adam. So out of all the diseases that is being used for MBA testing, you said vaccine preventable diseases, the waterborne diseases, and you also said MTDs. So this audience member is asking, what from all your findings, what would you say is the disease burden of the MTDs?
Yeah, I can just tell you a few, and some are still under analysis. I know that yours was found to be less than 5%. It wasn't that really much in Nigeria. But trachoma, even though the analysis is still ongoing, it varies from one part of the country to the other. And I said it earlier, it's higher around the northwestern part of the country. And once the analysis is done, we can be able to say, oh, this is the prevalence verbatim. Thank you.
Okay, great. Thank you, Dr. Adam. So if any members of the audience have any questions, please feel free to raise your hand. Any questions from the audience for our panelists? I saw a hand from Steve. Any other questions from our audience?
It's like we are good to go.
No, no, sir. No. So since it seems that we don't have any hands up, I think we can proceed with and final comments from both our panelists, if any, just to summarize what you would like the audience to go away from this integrated serosurveillance session with. Thank you so much. I think we'll start with Miranda.
Sure, thank you. Just to summarize, I hope that folks will look out for some of the publications that are forthcoming that Otto shared, so that you can continue to see the impact that integrated serosurveillance is having in Nigeria. And we are very grateful for the support that eHealth Africa and IHVN have provided for our grant to the Gates Foundation. It's been incredible to see all the success and progress that has been made, even in spite of the COVID-19 pandemic. So thanks for the opportunity to share today.
Thank you, Miranda. So a question just came in actually. Somebody just asked, how far are we from being able to have mobile point of care multiplex testing? Who will be the best person to answer this question? Is it you, Miranda?
I'm not aware of work on that. Otto, do you have any insight on that?
That's
the mobile POC multiplex that I'm aware of are not serological. They are not looking at antigen antibody. They are more of molecular stuff, what I have seen so far. But that's a good insight to start thinking around making it POC or mobile. That's like decentralizing the testing. But this is something that may take some time because even what we are doing currently is just emerging. So hoping that in the future, definitely that will be the way to go. Thank you.
Okay, is there any final comments before we round up the webinar? Dr. Adam?
Okay, for me, I would just say it has been a very nice journey with multiple funding, and as Stacy used to put it, it's a patchwork, but really it has made a great impact, and we can see how remnants of specimen on a DBS can give a whole lot of valuable information for public health importance in Nigeria, and hoping that this can be expanded to other African countries, and it should be assimilated within the countries to incorporate all other diseases that are even outside this. Thank you.
Thank you, Dr. Ado, and thank you so much to Miranda from CDCF and Dr. Ado from the NRL here in Abuja. Thank you so much for sharing your expertise and your insights on integrated serosurveillance. I'm sure that the audience has learned a lot about integrated serosurveillance. Okay, so we have a hand raised. Please, ICT, can you allow Steve Akinrinade to ask his question? Are you on the line, Steve? ICT, please unmute Steve. Mr. Steve, I think you're able to unmute yourself. Please, can you unmute yourself to ask your question? Mr. Steve, I don't know if you are aware that you are on mute, just in case you're speaking. Okay, it seems that he's unable to ask this question. So again, thank you to our esteemed guests and panelists for joining the conversation today. And thank you to the audience for joining in. And I hope that you've learned quite a bit about integrated national serosurveillance. And I will now hand over to our Deputy Director of Program and Impact, David Akpan, to give the closing remarks. Over to you, David.
Thank you, Nena. Thank you, Dr. Ado, and Marinda, I think it's been quite extensive, great insight into how best integrated surveillance has been able to improve some of the work that we've found in Nigeria. And it's a great learning point, for other countries in Africa. So thanks for sharing those insights. And very hopefully, we also want to acknowledge esteemed participants who've been able to find time to attend this webinar. And also to highlight that this is our monthly public health webinar series. So by next month, we should be coming forward with something very interesting again. And we'll also be identifying guests that will highlight some of the work that we are doing in the continent. We appreciate your time, and we also appreciate your contributions. Our team will reach out to everyone in terms of this content of this webinar is being recorded. So in case you need to preview it, so it will be communicated. And if you also have further questions, please through the feedback form, you can highlight them. We should be able to get Dr. Ado or Marinda to provide further insight to your questions if perhaps it wasn't responded to, or maybe something you thought of after this particular series. We appreciate your time, so thank you so much. And yeah, back to you, Nena. So close.
Thank you, David. So again, thank you to our audience for joining the webinar. And also I have to give a huge thank you and shout out to our ICT team and our communications team, Uche, Solomon, Muna, Favor, and James, and the rest for ensuring that this webinar was a success. And now there's going to be a post-webinar survey, so please feel free to fill out that survey just to give us your thoughts on the webinar and any suggestions that you have for us to improve the service. Thank you so much for joining, and have a good rest of your day.